for 4 weeks, worse at night. This wakes her up every 2 hours to dangle her feet off the bed, which she was told is due to a history of laminectomy. Here you have a direct SFA puncture in the proximal SFA with a Bernstein catheter level P3. A contrast injection demonstrates a trifurcation. Another injection at the same location in a lateral projection demonstrates multiple occlusions of the PT, lateral plantar, DP, and AT. Basically, you see the perineal supplying calcaneal branches that supplies the medial plantar, and the perineal supplying a collateral branch to supply the distal DP and anterior pedal loop. At this point, 2 wires were inserted in the Bernstein catheter. 1 wire was inserted in the anterior tibial artery, and 1 wire was inserted in the posterior tibial artery. The importance of inserting 2 wires is when you treat a lot of anterior pedal loops, it's easier to go and actually increases the speed at which you can work if you have a wire already down the artery. Choice PT was inserted in the PT, and Savient wire was inserted in the AT. A supporting catheter using a 2x40 Coyote ES was inserted over the Choice PT wire into the distal PT. At this point, the Choice PT was removed and a command wire was inserted. However, pushing the command wire, it wasn't feeling right. The Savient wire actually went from the collateralized perineal into the distal DP around the anterior pedal loop and into the native lateral plantar. So at this point, I felt the command wire wasn't going in the lateral plantar. How can you tell this? Basically, if a patient's foot is prepped, you can use ultrasound probe to identify if the wire is intraluminal or subintimal or actually outside of the vessel. And I recommend this technique for pretty much every tibial intervention you do. This is an IVUS down the posterior tibial artery, demonstrated we're intraluminal. So another good thing you can do is actually IVUS. IVUS demonstrates if you're intraluminal. So a Coyote 2x220 balloon catheter was inserted in the distal AT around the anterior pedal loop. At this time, however, I was unable to push the balloon any further. And I couldn't get the command wire to go into the native lateral plantar. So what do? What are the options? At this point, you could abort the procedure. You could try to remove the PT wire altogether and try to insert it down the lateral plantar again. Or you can actually cannulate the patent vessel that's in the distal foot. So using ultrasound, an 014 needle, the distal DP was cannulated and a Savient wire was inserted. This wire went over the same true lumen wire that was down the AT before. And this allows me to insert a 2x40 ES catheter, not using a sheath, and this allows angioplasty to be performed of the anterior pedal loop and lateral plantar to where I couldn't reach before with a 20x220. Once this angioplasty was performed, a command wire easily went around the anterior pedal loop and went into the native DP. Using that same 20x40 balloon catheter, the DP was recannulated and the wire actually went into the perineal artery. So now the anterior tibial artery wire went through the native DP. Once that was done, a 1.25 rotablator was performed of the posterior tibial artery down to the lateral plantar. Rotablator rotational atherectomy has been around for more than 25 years. Basically, it's a diamond-coated burr designed to peripherally engage calcium. And what this does actually pulverizes the calcium to smaller particles in red blood cells. Post rotablator angioplasty was performed with a 2.5x220 balloon catheter. Post angioplasty angiogram demonstrates patent anterior pedal loop, common plantar, lateral plantar, PT. An injection of the proximal PT demonstrates a patent posterior tibial artery. The 1.25 rota was then taken down the occluded AT artery. Now rota is only taken down to the ankle. I recommend taking the DP only if you see significant calcifications in the DP because it's a very superficial vessel and it can get stuck. After a rotoblader, a 2.0 by 220 balloon catheter was inserted and angioplasty was performed. Angioplasty of the proximal AT demonstrates a patent vessel and patent vessel down to the anterior pedal loop. An injection of the popliteal artery through the same 014 balloon catheter demonstrates a patent PT, common plantar, lateral plantar, anterior pedal loop, and DP. And what is interesting now, filling later, is the calcaneal branches of the perineal. Is pretty much what we saw only on the first injection. Post-procedure, all the patients are closed with a Kelp vascular closure device. Patients are placed at 45 degrees at 30 minutes and discharged at 1 hour. Her pulses were 2/2, respectively. What is a Kelp vascular closure device? Basically, a Kelp closure device is a device that can go through a sheath without exchanging the sheath. It goes through your native sheath. It can be used for 5 French, 6 French, up to 7 French. And it's a metal clipping that goes inside the artery and outside the artery. What's important about this is not that you can see it radiographically, but it endothelializes within the arterial wall, allowing no obstruction of the arterial lumen. And it allows actually early ambulation, immediate closure. There's many other benefits of Kelp closure device. Procedure time was started at 8:52, ends at 10:22. Total fluoral time is 36 minutes. Total dose 21 minutes, and total contrast use is 15 cc's. Total sedation time is 90 minutes. The importance of going integrate in an SFA puncture is your total fluoral time will be less, and the total amount of contrast you use can be less. Basically, the procedure supplies, I use a 2.0 by 40 balloon Coyote ES balloon catheter, a 2.0 by 220 and a 2.5 by 220, 014 Savion wire, choice PT wire, and command wire, and a roto wire, a rotoblader, Benson wire Bernstein, IVUS catheters, and 6 French Kelp closure device and Boston sheath. Now I'd like to discuss a second patient with you, L. Lung. Basically a 74-year-old man with a history of hyperlipidemia, renal cell carcinoma, and smoker since age 12. He states he has pain during ambulation and pain at night during sleep. He claims he can walk about 10 feet before he has severe pain. He has a DP that's 2+ and a PT non-palpable. Again, this is a level direct SFA puncture with the Bernstein catheter at level of P2 and injection performed demonstrating a trifurcation. This is a lateral view of the foot. The key takeaway about this picture is you see venous return before you see venous return at the time you start seeing perineal calcaneal branches filling the medial plantar. And this injection took over 8 seconds to even get to there. Again, a double wire technique. The anterior artery was cannulated with a Savion wire and the posterior artery was cannulated with a choice PT wire. However, the choice PT wire stops and goes into a collateral. The anterior tibial wire was then taken around the dorsalis pedis into the anterior pedal loop into the lateral plantar. At this time, a balloon catheter was inserted as my supporting catheter, and the wire was inched up into the common plantar. And you can see here now the wire is going to the distal PT. What's important about using a 2.0 by 40 balloon catheter, it can be inflated and using as a supportive device. Basically allows for wire advancement. Here the wire buckles and goes up the PT. However, at this point, as I pushed up more, the wire was going lateral to the proximal PT wire. So I thought something was wrong there. Here's an example of a push wire technique. It is very important to note you can make a loop in a wire. The Savient wire particularly makes a small loop. The command wire can make a loop and actually go through a CTO. Just use techniques of looking with ultrasound to see if you're true lumen, do IVUS to see if you're true lumen. At this point, a Navicross was inserted to take the wire out of the collateral, and a command wire was inserted. Basically, I formed the track already in the common plantar. In the distal PT, the command wire flew down the lateral plantar. IVUS was then performed. IVUS shows no disease in the anterior tibial artery or DP. That wire was removed. IVUS confirms we're intraluminal in the posterior tibial artery. A 1.25 Diamondback was used, or CSI, in the mid, common, and lateral plantar. It is very important to note you can do atherectomy up into the base of the fifth metatarsal. I personally don't advise going into the anterior pedal loop due to the figure eight rotation that the arteries have to the DP. It is safe to do up to here. Just no greater than 1.25 burr. Angioplasty was performed 2.5 by 220 balloon catheter of the anterior pedal loop and common plantar. This is an injection through the balloon catheter. Basically at the DP you see a little bit of vasospasm from the ballooning. Pullback angio demonstrates patent anterior pedal loop and lateral plantar. Proximal PT injection demonstrates a posterior tibial artery that's patent. Again, procedure time was 11:23 and ends at 12:20. Total fluoro time 19 minutes. Total dose 24 milligrams. Total contrast used is 5 cc's. Basically, when you go direct SFA, you can inject, you can pass the wire and only have to use 3 cc's in a 10 cc syringe of contrast to saline ratio. Basically using 3 cc's per 10 cc's and saline mixed with that allows you to do 1 syringe injection at the lateral foot and anterior knee, and then the other times use 3 cc syringes with 1 cc of contrast and through the balloon catheters. Total sedation time is 57 minutes. Post-procedure, again, the patient was closed with a Kelt vascular closure device and placed at 45 degrees at 30 minutes, discharged at 1 hour. Pulses were 2/2. Procedure supplies. Basically, I use the same thing that I've used on the other case. Basically, it's the same thing every time we do a tibial case. It's pretty systematic. You can stay systematic and do everything the same way, and actually results are phenomenal. Only here I changed the rotowire for a Viper wire, and I used the 1.25 Diamondback. Thank you very much. Hope you enjoyed the lecture.